Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions are submitted via the Q&A, as they will be answered at the end of our lecture. Today, we have a very special individual. Originally from Winnipeg, Canada, she boasts first-class double honors in biochemistry and physics, plus an MD and PhD specializing in insulin resistance, metabolic syndrome, and pregnancy. With a rich background in ICU and emergency medicine, she's served remote communities, she's delivered babies, and has provided critical care. She's worked with the Mayo Clinic, Providence Health, and the University of Washington. Now, she resides in the Midwest, and she has co-founded Firefly Medical Group, which offers cutting-edge hormone treatments. Her unmatched expertise and passion make her stand out in the field. Without further ado, Dr. Lovat.
Thank you so much for the great introduction. So today we're going to be going over the hormonal aspects of addiction. We have a big problem with addiction in this country, in our population, and it's very important to understand it on a hormonal level. I'm just going to click in here. So in terms of disclosures, I have no relevant financial disclosures to disclose. However, this topic is very complex and we have a very short time to talk. So we're going to go over something that's very in-depth, very superficially. So my objectives for you for today is to explore some of the gut-brain opiate pathways that tie all addictions together and how they relate to hormones. We're going to talk about obesity, as in obesity is an addiction as well to food and sugar, and the strong relationships it has to other addictive behaviors. We're going to talk about how to take an empathic and personalized addiction history from patients that are already sober from your perspective and are actually maintaining sobriety, and how to get that history out of them. And then I'll talk briefly about a couple of my own patients that have had some complex history and addictions, and how the use of off-label bioidentical hormone therapy can help them maintain their sobriety and reduce cravings. In terms of the references for this talk, you'll see them at the very end, and there will be a big bibliography as well if you want to look at any of the manuscripts I've used for references. Now, one thing I should also disclose is I have an addiction too, and it's to memes, so I always put them in my talks. So if you know anybody else that has a problem with memes, just dial that number at the bottom of the slide. So let's talk about what addicts the human animal. And as animals, we are susceptible to addiction because we have that gut-brain connection. So if we look at the most common addictions, number one is food. It's processed now. It has additives made by chemical engineers in order to make it more addictive. Sugar and carbohydrates at levels that you don't see in nature. A mixture of carbohydrates and fats, especially plant oils and seed oils. And then sweeteners with salt combinations, for example, like Diet Coke, which is a huge salt load coupled with a sweetener. I would say nicotine and alcohol would be two other big addictions in our country. Opiates are, in the last 30 years, have really taken off. And then there's things like gambling, sexual acts, and video games that would come basically. That would be a list of the most probably 90% of addictions in your patients. So why are those addictions so prevalent? Well, there's a reward circuit that we have in our brain that connects to our gut that's supposed to reinforce behaviors that are associated with success. So biological success, reproductive success. And unfortunately, those substances hijack that connection. And it's in the brain, in the VTA-NAC circuit. Long-term abuse results in actually abnormal activation of the dopamine neurons in those reward circuits. So for example, having a dopamine rush from having sex would be a biological success, reproductive success reward. However, if you were to use methamphetamines, you'll get 2,000% more dopamine from that. And so you have this long-term abuse, which makes regular behaviors that should be helpful into something that actually is harmful, because you can never get that dopamine from a normal activity that you could get from a drug. In nature, this would be something like you're a caveman and you see a beehive hanging off a cliff. you might decide it's worth risking your life to go get that honey, and you get that reward from eating that honey because your body wants you to intake those calories. So another level of this brain-gut connection is your microbiome. Your actual microbiome, which is the healthy gut bacteria that you host in your gut, are actually changed by substance abuse. And there's actually a microbiome gut-brain axis that directly affects the HPA axis, which controls all of our stress responses and regulates our hormones. It changes your intestinal barrier and how well you can mount an immune response. And it also can change the neurotransmitter production. So serotonin, dopamine, and as well as the metabolism of how those neurotransmitters are broken down and how long they can last inside the body. There's also a vagal nerve component. So the vagal nerve is the parasympathetic nerve innervation to the gut. Parasympathetic nervous system is the brake, so rest and digest. Vagal nerve stimulation actually reduces addictive behaviors. And unfortunately, things like chronic alcohol and chronic sugar ingestion actually damages the vagal nerve. Therefore, you're taking the brake off of that reduction in addictive behaviors. And then you are missing basically a huge component of your ability to control addiction. So in terms of how you take this substance abuse history, so a lot of my patients will come to me with, I want you to fix my hormones. I'm having trouble with my weight. And you have to tease this out because it will help you understand how that patient got to where they are. I ask people, have you ever used drugs or alcohols or activities to make yourself feel better? So you can either start with a hormone problem and self-medicate, or you can make a mistake, get addicted to a substance, and then that can cause your hormone problem. So it's really important to tease that out. And then do you feel like you're out of control, or you have been out of control with your use of those tools? And that's getting at the side of things where if you are somebody that doesn't have control over your use or your behavior, that's more likely you have substance abuse. I also ask if they've ever been treated for addiction. So there's patients that might have actually been admitted to rehab a couple of times or needed assisted detox, if they've lost any jobs, relationships because of those behaviors, or if any close relatives that were in the home actually also have those types of problems. So mother, sisters, aunts, grandma, fathers, brothers, uncles, grandpa, do they have substance abuse? Because being exposed to that as a child can actually damage your hormones as well. And the big area of research on this, there's a really good score. And if you haven't heard of it, you should go Google it after this talk. It's the ACEs score, Adverse Childhood Experiences score. And it's scoring you from a scale of 0 to 10 on things that would be considered abuse, neglect, or other adverse experiences. We're not sure whether or not this is like a brain injury or a TBI equivalent that's psychological. And we know that TBIs initiate a cascade of inflammation in your brain, and they affect your hormones for 20 or 30 years. So these main categories are abuse, neglect, and household dysfunction. So you can see they add up to 10. So abuse could be physical, emotional, or sexual. The neglect could be physical or emotional. And the household dysfunction could be a caregiver with mental illness, an incarcerated parent, if mother or father were treated violently, any substance abuse in the home, or divorce. And so if you think about your patient population, a lot of kids are kids whose parents got divorced. Well, that's already 1 point. Maybe their mother had anxiety. That's 2 points. Maybe because of the anxiety, that mother couldn't take them to the doctor or make them lunches and they felt neglected. Well, that's emotional neglect. That's 3 points. It's not that hard to accumulate, at least 2 or 3 points. Any score of 4 or higher is almost guaranteed to give you some kind of chronic disease. And those chronic diseases are caused by insulin resistance and substance abuse. Another very common hormonal problem you'll see in your patients is PCOS. So PCOS stands for polycystic ovarian syndrome. It's a bad name for the disease because really it's like a female insulin resistant syndrome where you have low progesterone and lots of thyroid symptoms and excess androgens. So you get acne, thinning hair, excess body hair. But one of the other things it does is it dramatically affects your mental health because you make less progesterone. So women with PCOS are way more likely to have personality disorders, depression, anxiety, and then that triggers addiction because they're self-medicating to treat their mental health issues. And the underlying issue in PCOS causing that is a lack of progesterone. Progesterone is the feel good, relax, go to sleep, everything's going to be fine hormone. And in women, if you don't have PCOS, you're going to be more, if you don't have progesterone, I should say, you're going to be way more anxious and neurotic. They also don't have as much thyroid hormone, whether it's thyroid hormone resistance, an inappropriately low TSH. They have a lot of thyroid symptoms like weight gain and constipation and feeling cold all the time. And that can also cause depression because we know low T3 or low active thyroid hormone can be a big contributor to depression. 40% of them will have infertility, and that is a disfiguring, awful experience for them to go through, and that can also trigger additional mental health issues. And then if they have a very severe form of PCOS, which is about 50% of them, they'll have obesity and they'll have outward signs of their PCOS. So acne, hair growth, like the women with a huge neck, and they have a beard and they have terrible acne, and that's disfiguring. And another layer on top of this is what PCOS is likely inherited in an autosomal dominant fashion. It's likely genetic when they look at family tree studies. And so they're being raised by women with PCOS, aunts, grandmas, sisters, moms, who are also mentally ill or have addiction problems, which ramps up their risk of mental health disorders. If you look at why progesterone seems to be so good at controlling female anxiety, well, we know that the GABA receptor is very important in anxiolysis. So the alcohol and benzodiazepines both bind that GABA receptor, and a GABA receptor, when it's stimulated, is a brake on the central nervous system. So it causes calmness, improved mood, sleep. So these women don't have progesterone, which is a natural ligand for the GABA receptor via its metabolite allopregnanolone. And so they figure out pretty early on, if they're going to go towards alcohol or Ativan or Valium, that they can compensate for their lack of progesterone with a benzodiazepine or with alcohol. And if you have low progesterone, which is supposed to be stimulating your GABA receptor to calm yourself down, then you're going to have low GABA function, and low GABA function will cause anxiety, depression, insomnia, and increased excitatory neurotransmitters. So how could that not cause mental health issues? Another layer of this lack of progesterone in women, progesterone is also neuroprotective, meaning it protects your brain. It increases BDNF, which helps you repair nerves and brain tissue. It increases the protection sheath myelin around nerves. It reduces glutamate responses, and it also limits how much cells can induce programmed cell death or necrosis. And unfortunately, the alternative medications that they might be using to self-medicate, like alcohol or Ativan, are not neuroprotective. And in terms of women with PCOS, I'm sure you guys have seen this show on Netflix, and one of the things that women with PCOS feel like is they always feel like they're kind of those crazy girls that, you know, if something bad happens, they freak out way more than somebody that doesn't have PCOS, and it's because of the lack of progesterone. They don't have their mood stabilizer hormone. If we look at other pathways, another common addictive issue is the opiates. And opiate receptors and hormones have very complex crosstalk. So in both sexes, the mu receptor, which is an opiate receptor, actually reduces GnRH. And GnRH is the brain hormone that's going to actually cause secretion of LH and FSH, which will then cause production of sex hormones. So if you have opiate receptor activation, you lower GnRH, centrally lowering the production of sex hormones. And if you think about the drug, let's say Lupron, that's how that works. It shuts off GnRH, and it has a lot of bad effects on your hormones. In nature, that release of an endogenous opiate would normally be triggered, that amount of opiate activation that you would take when you take a Percocet would be triggered by trauma. So let's say you look back at a caveman who's fighting a bear and he gets hit in the head and maybe one of his arms gets broken. He's getting his own endogenous opiates for pain control. Well, the body is preparing to not reproduce because you need time to heal. You just got attacked by a bear. But if you have increased exogenous opiates, that level is so much higher and it's constant, you actually lower the fertility chronically because you're shutting off hormone production. It actually also regulates pancreatic function, opiates. So beta endorphin has actually been found to inhibit insulin release from isolated pancreatic beta cells. And endogenous opiates are heavily involved in those reward circuits as well that regulate hedonistic behavior and food intake. So if you stimulate opiate receptors, you're going to promote feeding, i.e., you're going to be hungry, irregardless of whether your body's actually satisfied. And if you block opiate receptors, you can actually induce weight loss in diabetics and women with PCOS. And so it's another layer of the hormone addiction pathway. And if you look at your average opiate abuser, they tend to have a huge belly, very skinny arms and legs, like they don't have hormones. If you look at a beta endorphin infusion in suppressing catecholamine levels in both healthy people and people with hypertension, mu receptors actually inhibit the adrenal response as well. So long-term opiate treatment can actually cause suppressed adrenal function. And we have multiple hormones in our adrenal glands that are very important at regulating blood pressure, salt balance, cortisol, DHEA. And so opiates, again, are shutting that off as well. So long story short, if you have prolonged non-natural exogenous mu opiate receptor stimulation, you can get cessation of multiple functions that cost energy. That's the take-home point here. And if you look at the hormone pathways, you're going to inhibit reproduction by inhibiting GnRH. You're going to stop making as many micromolecule synthesis. You're going to reduce insulin secretion. You're going to reduce tissue renewal. You're going to lower cardiac function, causing hypotension, and you're also going to reduce your drive to breathe. So you're going to save energy that way. You're going to slow your GI motility. Part of that is blocking thyroid hormone as well, causing the constipation, but it also is a mu receptor effect. And then you're going to reduce your HPA axis activity, and you're going to actually have immunosuppression by turning off some of your inflammatory responses. In terms of what the mu receptor actually is, it is one of the G protein coupled receptors, and it gets internalized after it binds the agonist, so the opiate. And actually, estrogen induces the release of endogenous opiates that in turn activate the mu opiate receptor. So if you think about, again, PCOS, where you have high estrogen and low progesterone, that's another factor for those women. And enkephalins and beta endorphins are non-selective endogenous mu opiate receptors. So it's again, when you think about how we used to use opiates before a lot of the drug company marketing in favor of we need to control pain, pain's a vital sign. We used to only use opiates in patients that had severe surgical pain or end of life because we knew the effects that they had. If you look at progesterone again, it actually blocks the estrogen-induced opioid release, relieving that estrogen inhibition, and it actually facilitates lordosis, relaxation of the spine. And I'm not sure how many patients you see with PCOS in your practice, but I see a lot. And a lot of them have chronic back and neck pain. And when you give them progesterone, it gets a lot better. And I hope that they come and see me before they get something as invasive as a spinal fusion or back surgery, because a lot of them will get premature degenerative changes, and it's from this estrogen-progesterone imbalance. For men, a huge part of the downside of opiates is chronic opiates lower testosterone in men by up to 90%. But if you give them testosterone replacement, you actually restore the mu opiate receptor mRNA and protein levels after opiates. So testosterone is regulating that peripheral mu opiate receptor regulation system. In terms of the thyroid aspect, so opiates actually stimulate TSA secretion and suppress prolactin secretion. However, it increases the total T3, but it decreases the serum thyroid binding capacity and free T4 levels. So you're actually going to get less thyroid at the cellular level, although your total levels might go up. And then in terms of changing lanes here to head injuries, we know that when Chuck Norris shoots heroin, he actually causes his dealer to overdose. And I do also enjoy Chuck Norris memes. So in terms of taking a different direction here and looking at PTSD, TBIs, and brain inflammation, Dr. Mark Gordon is actually a great resource for this topic. And I put his website in my slide here. He talks about traumatic brain injuries and the neurosteroid dysfunctional system. syndrome, I should say. So there is a parallel hormone system that exists in your central nervous system. And psychological or physical trauma, i.e. ACEs, so adverse childhood experiences or trauma that you acquire as an adult, or a physical injury can set off this inflammatory cascade, and it can last for decades. So you get a head injury at 15, you're getting affected by it at 45. This inflammation changes hormone production, sensitivity, and feeds back to the gut and all the endocrine organs. So what's important here is to understand that you should also be asking your patients whether they've had any significant psychological trauma or any significant head injuries. Because, for example, if we look at thyrotropin releasing hormone, which causes TSH to be produced, patients with this neuroinflammation, they don't make appropriate levels of TRH. So you can't use their TSH to understand if they have a thyroid problem or not. One very common drug that is becoming more and more popular as it gets legalized in various states is marijuana. Most marijuana users say it's not addictive. I just saw an article today that said there's now more daily marijuana smokers in the US than daily drinkers. Clinically, I disagree. And it also, excessive cannabinoid receptor stimulation does similar things to opiates. And so it can cause insulin resistance, reduced energy. And the use of marijuana for me is a red flag. They're self-medicating for some reason. Do they have a thyroid problem? Do they have PCOS? And when you take the substance abuse histories that I have, a lot of people do start with marijuana. They don't go right to heroin or meth. And so it's something that you should be just watching for in your patients. When you look at gastric bypass patients, so patients that have significant obesity, they got their stomach amputated, there's something really interesting that happens. They get a new onset addiction in a significant number of patients. It's called addiction switching, meaning they can't eat anymore, and that was their addiction. So now they start smoking, or they become an alcoholic, or they start gambling. And if we look at long-term studies, 95% of them fail to keep the weight off. So we're taking a person who has probably a hormone problem, we're amputating their stomach, and then they're going to get addicted to something worse, and they're going to get fat again anyways. And to me, that kind of blows my mind. I think we're going to look back at gastric bypass as like lobotomies, because we're amputating a healthy organ because of a metabolic and hormone problem. Now, in terms of how did we get here, this opiate epidemics that we've been going through. Actually, during the Civil War, the first opiate epidemic in modern history was actually when they sold heroin to use in infants, basically as pain control. So that's kind of crazy. Like infants, we can all agree, shouldn't be on heroin. The second one was when all the veterans came back from Vietnam and they had come home with addiction. And then in the 90s, we went hog wild at getting the pain scale in and selling drug company opiates. So if you gave opiates, you're a compassionate doctor. If you didn't, you're a terrible doctor who doesn't care about their patients. So big pharma seduced the prescribers. Patient satisfaction became much more prevalent, like your Press-Ganey scores. Do you feel like you got value from the visit? And then that pain is a vital sign. And there's a really good documentary on oxycodone that you can watch on Netflix called Painkiller, and you can kind of go through some of how they got this drug on the market, and they knew that it was going to cause addiction. And now we have all these great clinics now that help treat all these addictions with opiate replacement therapy, and they get to make money coming and going. So helpful approaches, addressing the root cause. Obviously, you might not be able to eliminate the root cause, because if it's from childhood trauma, you can't go back in time and take that kid and put it in another family. But there's complex gut-brain connections, and they have a very strong hormonal basis. My approach is optimize all hormones first. So if a patient's coming to me and they're active addiction, but they're functional enough that they can show up to my office, they can take medications, I'm not giving them anything that's going to interact with what they're using, then I'm going to focus on optimization first, and then I'll help them with their addiction once they feel good enough that they're willing to eliminate their crutch. So give women a new GABA agonist, progesterone, give men a new source of dopamine, testosterone, and then give them both improved energy and motivation and metabolisms by replacing thyroid. Addiction is a gut-brain injury until proven otherwise. Approach patients with high ACEs scores or concussions as if they have a PTSD or a TBI. And one thing Dr. Gordon goes through is actually pregnenolone is maybe not the strongest supplement in the world, but there are rapid responders. And patients with brain inflammation tend to respond really well to pregnenolone, as well as DHEA optimization, even if they're younger. Another tool in our belt for addiction management and hormone management is off-label GLP-1 medications. This is like things like Ozempic and Mounjaro. So GLP-1 drugs appear to help with reduction in addiction. So they did a study where they gave binge drinkers access to as much alcohol as they wanted, and they also put them on a GLP-1 drug, and they reduced their consumption by 50% without trying. So that was a passive reduction. And in my experience, it seems to reduce all addictive behaviors, including gambling, things like that. And I tell my patients, try to use this effect consciously, because you can outdrink, out-inject, and out-eat any intervention if you're not ready to quit. And that's what we see with the gastric bypass patients. They weren't ready to quit eating, and they relied on the surgery, and then they were able to eat through the surgery. Another drug that I'll use off-label is naltrexone, and it acts as a very powerful anti-inflammatory when it's used at low doses, for example, for autoimmune or chronic regional pain syndrome. But it also blocks reward pathways at higher doses, which reduces the addictive behaviors by reducing the reward. It's an antagonist at the mu-opiate receptor, and it prevents opiate intoxication and physiological dependence. And the way it affects inflammation is it's actually blocking toll-like receptor 4 on white blood cells. And the microglia are going to produce inflammation, pain, fatigue, insomnia. So if you get chronic microglia stimulation, you get neurotoxicity, and naltrexone is blocking the ability of those microglia to be as active. So conditions where I'll use naltrexone that are for autoimmune be like Hashimoto's, Graves, rheumatoid arthritis, lupus, maybe even psoriasis, chronic fatigue syndrome, those types of conditions. Some clinical issues with naltrexone: you need to monitor liver function while they're on it. There's been some rare case studies of eosinophilic pneumonia secondary to being on it, and you want to be stopping it before surgery. 3 days if you're on oral, 30 days if you're on injectable, because if you need opiates for postoperative pain and you're on naltrexone, they won't work. You can initiate it in all patients with addictive behaviors, and obesity, in my opinion, is a sign of food addiction. You can do 1 to 1.5 milligrams nightly and an increase every month by 1 to 1.5 milligrams. In alcoholism, Mayo Clinic has a great dosing guide on their website. You take 50 milligrams a day for alcoholism. And then opiates, you do 25 milligrams for dose 1. An hour later, you take 25. And then those are various dosing schemes. The big thing with naltrexone, though, if you're an alcoholic and you're done being sober, you just stop your naltrexone and you wait a few days and then you drink. So the patient has to be on board with the sobriety, because if they're not, they're just going to stop the drug because it's something that they have to do. It's not required. In terms of my dosing for progesterone, one of my biggest pet peeves is when people underdose progesterone. The only condition on the planet, the medical condition on the planet that has high progesterone, is pregnancy. And we never drop women's progesterone in pregnancy. We give them extra progesterone. So there is no upper limit. You start at 100 milligrams of immediate release at bedtime, and you titrate to effect. And you can use under the tongue doses for cravings during the day or anxiety. So in terms of the take-home points, addiction is a gut-brain hormone problem. Treatment is not a one-size-fits-all. And patients who struggle with addiction have a poor hormone problem until proven otherwise. So with that, I'll take some questions.
Dr. Lovat, excellent presentation. I do have a few questions for you, with the
Sure.
first one being, are there any specific patient populations that benefit most from hormonal treatment for addiction?
I think the younger you can get the patient, the better. The longer they've been in active substance abuse, the harder they're to treat. But really, any patient with an addiction is an optimal patient to get on hormone therapy to optimize. because these hormones aren't addictive. They just make you feel good, but there's not that synthetic dopamine rush from being on them. They're natural.
Excellent. And on that note, based on your experience, what are some potential side effects of using hormonal therapies for addiction that you've experienced?
In terms of side effects, you get similar side effects in addicts as you would in patients who don't have addiction. So progesterone can cause some nipple sensitivity, some morning grogginess, and menstrual cycle changes for cycling women, but it's temporary. And then usually you just feel good. Thyroid hormone, when you're initiating that, if you go too slow, you can become cold and tired. If you go too fast, you can become jittery, like over-caffeinated is how it feels. So then again, you adjust the dose based on side effects. And then testosterone is a little different in men and women, but in general, you can get some acne, hair growth, hair loss. But generally speaking, within a few weeks of testosterone replacement therapy, patients are feeling improved, like mood, motivation, sex drive, those types of things.
Excellent. And would you say that a prolonged use of progesterone causes imbalance in estrogen?
No. Estrogen progesterone ratios do not, that's sort of, I just had that question actually from a patient today. The higher the dose of progesterone, that women with PCOS have another layer to their disease. It's called progesterone resistance. So they're less able to make it, but they need more. So you titrate the hormone level up until the patient feels good. And unlike insulin, which will develop insulin resistance with time, you don't get progesterone resistance that increases from your baseline. So once you get to the dose where you feel good, you just maintain them at that dose. When you're not in menopause, your estrogen levels or whatever your ovaries are going to make. And because progesterone is bioidentical, it does not suppress ovarian function like birth control. So you will still cycle your normal way. And then at menopause, you can initiate estrogen.
Excellent. And it seems like this question is from an individual who is not on the hormone wellness space or in the space.
Mhm.
So, how can a provider who is in the addiction space integrate hormone
Yeah.
therapies into their practice?
That's a great question. So the best place to get hormone training is WorldLink Medical. It's currently taught by Dr. Neil Rousier. He's an ER doctor. He's been doing this for decades. He's got a great teaching style. He brings up paper after paper after paper, substantiating what evidence we're using to prescribe these hormones the way that we do. And that you would take, there's 4 parts to it. So you would start with part 1. And part 1 is designed for you to be able to integrate it into your practice right away. You're not going to be an expert yet, but you definitely have everything you need to start. And somebody who's already working in the addiction space, this is like great because a lot of these people have insulin resistance and diabetes and hypertension and insomnia and mental health issues that aren't being addressed by the opiate replacement therapy. And so you're going to have better remission of those addictions, and the patients are going to feel better if you integrate the hormone therapy with it.
Excellent. And Dr. Lovat, as far as the questions, that is it. Amazing, amazing presentation. On behalf of Access, we would like to thank you again for an amazing lecture. To our audience, thank you for tuning in to another Access Live. Video will be shared with everyone. So stay tuned and stay healthy. Thank you, everyone.